Hello, everyone. Welcome. We'll be starting this webinar in a minute. Hello, everyone. For those just joining us now, we are about to start this webinar, just giving 1 or 2 minutes for people to join. Hello, everyone. Welcome. I'm seeing people joining. We are going to start in a minute. Hello, everyone. Welcome. It's a great pleasure to gather us here today for the discussion on the path to precision diagnosis. And the topic is strengthening clinical confidence and cardiac image efficiency. My name is Alexandra Gonçalves. I'm a physician, a cardiologist, and I work for Philips Healthcare in the United States. And I wanted to start this message for you today by sharing what we do at Philips and what is our mission. So our mission is to make the world healthier and more sustainable through innovation, and it's a very ambitious one because we aim to improve the lives of 2.5 billion people a year by 2030. So that's what drives us every day, and that's why we are here today. And the way that we see our contribution is across the healthcare continuum. It's from healthy living to prevention, diagnosis, treatment, and then the time back home in the home care. And whatever we developed is with the thought process of improving patient experience, of improving the health outcomes, improving the staff experience, and lowering the cost of care. The last year was a tremendous challenge for all of us across the globe. And it was an example how putting these different paths together can bring up a meaningful contribution. So here we have some of the solutions that we brought into the fight against COVID-19. And more towards the focus of today, we have computed tomography, diagnostic X-ray, point of care ultrasound, advanced informatics, and etc. MRI that contributes to this as well. And then the connection to the monitors and invasive and non-invasive ventilators, and how does all of that links with the central monitoring, tele-ICUs, telepathology, telemedicine, and all these words that became part of our reality in the latest year. So with that, also, it reinforced even further how much we are able to do together. And together means the healthcare providers, means the industry, means the academic centers, means all the payers, means all this ecosystem that are helping us to have a healthier world. So with that, I'm very excited for today's session. And I would like to introduce our first speaker. Our first speaker is Dr. Danrad, and Dr. Danrad is going to talk with us about the CT use of spectrum CT. And I'll pass the word to Dr. Danrad coming up next. Dr. Danrad is an associate professor of clinical radiology and associate professor of internal medicine at LSU Health, New Orleans, and we are very excited to hear your talk on spectral CT and cardiac imaging.
Welcome to webinar on spectral CT and cardiac imaging. I'm Raman Danrad. Here is my disclaimer, and I'm thankful to Philips Healthcare for sponsoring this webinar and antmini.com for making logistic and the platform available for streaming of this webinar. Goals and objectives are that after attending this presentation, the attendees should be able to describe role of spectral CT in cardiac imaging, discuss advantages and limitations of spectral coronary CTA, understand adjustments in the scanning protocols for spectral coronary CTA, and hopefully would be able to interpret cases using spectral data set. There are 4 types of dual energy CT scanning system that are available in the market. The first one here has KV switching with a single source X-ray tube that switches between high and low KV and thus generates high and low energy data set. This second one has 2 X-ray tubes, one with high KV and other one with low KV, and that's how it generates dual energy data set. The third one has 1 tube, and the patient is scanned twice, one with low energy and other one next time with high energy, and that results in dual energy data set. The fourth one is unique because it is a detector-based system. It has a spectral detector which can discriminate between the high and low energy X-rays, and there is no need for additional tube or additional scanning or KV switching. This is called spectral CT. So spectral CT has a spectral detector, and I would argue it is ideally suited for the cardiac imaging due to perfect spatial and temporal co-registration of the data. And that is very important for cardiac imaging since the heart is a moving structure. So both the low and high energy data should be perfectly co-registered in the spatial as well as temporal domain. And for the spectral CT, it is a great advantage that it is always on, which basically means that we do not have to decide beforehand whether to do a conventional scanning or to do dual energy scanning. Since the data is always available, which can be summoned later on for the analysis. And it has a few advantages. First of all, there is only one protocol, so there is less chance of confusion and less chance of mistake by the technologist. And also, the technology doesn't need to decide beforehand whether to do a dual energy data or to do conventional images. And it is also good for the imagers because they do not have to tell the technologists beforehand what kind of protocol is to be used. There is superior reporting for the incidental findings because by definition, we cannot know the incidental findings beforehand before the scanning is done. So by gosh, so many times we think that, oh, we see this incidental finding and hope we had the dual energy data. But with the spectral CT, that is not an issue because the dual energy data is always available for analysis. And since we are not scanning the patient twice, or we are not KV switching, or we are not using 2 tubes, there is less radiation dose. And since cardiac imaging is dose intensive, radiation dose is intensive, so it is better to use the spectral CT, which has less radiation dose. And also at our institution, we have found out that the system is body habitus neutral, which basically means that it works as good for the patients with large body habitus. And we'll see the example of that in the following slides. Advantages of the spectral CCTA are that we can use 50 to 70 cc of contrast, which is low dose, and get quality diagnostic images for the coronary arteries and also for the heart. And if for any reason there is bad bolus, which may be because of mistake from the technologist or equipment failure or low ejection fraction, we can rescue the bad bolus by using 45 keV mono energy data. Since the dual energy data is always available, so we have that available to us, and actually the scanner can send that data automatically to the PACS. And those who have done cardiac CT know that finding thrombus in the left atrial appendage versus flow artifact is not very uncommon, and that can sometimes be very challenging. And we'll see um, in the following slides, we'll see an example of this entity. And there is a big limitation that is the detector size is small, it's 4 centimeters in size. And for this, we need a robust heart control, and the rhythm control and retrospective gating is preferred, so that if there's motion artifact in one of the phases, we have a backup phases. Heart rate is kept less than 75 beats per minute, and the system is robust enough to tolerate this heart rate. The gantry rotation time is very less. It is 0.27 seconds. That means a little less than 4 rotation in a second for the gantry. Beat variability should be kept plus minus 5 beats per minute. That can be achieved using pharmaceutical agents. The contrast is given in 3 phases. First phase is 100%, followed by mix 60-40% with saline, followed by 0% saline contrast. Contrast bolus is given in 3 phases. First phase is 100% contrast. Second phase is mixed of 60-40% contrast. And last phase is saline bolus. Scanning is with low pitch and use of iterative model reconstruction, which decreases the noise and also decreases the dose. Here are the examples for the different heart rates. And here the heart rate is 50 beats per minute, and we see nice RCA and the LAD. And at the heart rate of 78 beats per minute, we see fairly good RCA and the LAD. And this example was done for a TAVR patient. And here also we see relatively motion-free RCA and LAD. And these examples show that the system is pretty robust even at the high heart rates. This is an example of the poor bolus on the conventional images. We see that there is lack of extraction of the LED on the automated system. But since we have 75 keV iodine boost images, we can summon those, and it was beautifully auto extraction of LED. And this helps with the workflow because we don't have to extract the coronary arteries. If there is PVC or arrhythmia, then EKG editing can be done like any other scanning system, and we can get rid of motion artifacts at the aortic root or the coronary arteries. Interpretation should be done using Danrad system for the coronary arteries, and then of course we look at chambers and pericardium, great vessels, and extra cardiac structures should be assessed at large field of view. Since the data is available, so we should always increase our field of view and look at the rest of the lungs and the thoracic wall and the soft tissues for any abnormalities, and we should give that benefit to the patient. Here is the Danrad scoring system. Danrad 0 is no atherosclerotic disease. Danrad 1 is the atherosclerotic disease causing stenosis between 0 to 24%. Danrad 2 is stenosis between 25 to 49%. Danrad 3 is stenosis between 50 to 69%. Danrad 4 is between 70 to 99%, and Danrad 5 is complete occlusion. And that is important because Danrad 1 and 2 is treated medically. Danrad 3 is referred for nuclear stress test or stress echo, and Danrad 4 and 5 usually result in refer to our interventional cardiologist colleagues. There are various spectral results that are available on the scanner, and we have found that mono 70 kV, virtual non-contrast, iodine, no water, and iodine density are the most useful for the cardiac and coronary assessment. And here are the examples. This is a conventional image. And this is mono E70 keV, which is equivalent to the conventional image as far as attenuation of the structures is concerned. And here we already see that the noise is reduced because because the low energy data is no longer here, and the quantum model which was seen in the conventional image is gone. This is a virtual non-contrast image, and this is iodine no water, where we see very nicely the presence of the iodine and very nice enhancement of the chamber and the myocardial wall. And this is iodine density, and this is Z effective. So Z effective is ratio or the scaling based on the atomic number, and sometimes you find it useful to look for fatty structures in the myocardium or around the myocardium. Here is an example of the conventional image on the left side and virtual non-con image on the right side. And there is a calcified plaque in the proximal LAD causing stenosis. And here the stenosis appears more because of the blooming artifact, which goes away on the virtual non-contrast image. And that's what we have seen in our practice, that the spectral results, particularly virtual non-contrast, correctly downgrades the Danrad scoring from the dense atherosclerotic calcified plaques. In this example, we see that the lumen of the stent is seen better on iodine no water results compared to the conventional image because the beam hardening and the blooming artifact is reduced. This is an example of a densely atherosclerotic plaque in the proximal LAD, and we see that the differentiation of iodine density in the proximal to the distal segment is less clear on the conventional image compared to what is seen on the iodine no water and iodine density image. The difference is best seen on the iodine density image, that the pre-stenotic segment is very well opacified, whereas there is decreased opacification of the post-stenotic segment. And that's what we have seen in our practice. And when we see finding like this, that helps us and increase our confidence in saying that this is a flow restrictive stenosis. This is an example which shows there is a high point density in the infralateral portion of the left ventricle. Difficult to tell here whether this is a beam hardening artifact or it's a real finding or not. But once we look at our spectral results, this is the iodine no water. It very nicely shows lack of contrast in that segment, very beautifully shown on the color overlay image. And this increases our confidence that this is infarction and not an artifact. Here is the culprit lesion in the left circumflex artery. Similar kind of situation, another patient. Again, we see here there is hypoattenuation in the posterior portion of the posterior inferior wall, and also in the apex of the heart. It's difficult to tell whether these are beam hardening artifacts or real findings or not. But since the study was done on spectral scanner, we can easily summon our spectral results. And here we see that there is no infarction. This is all beam hardening artifact, and there is a very nice perfusion, particularly seen on the color overlay image. This is an example which many of us have seen, not that rare, is a filling defect in the left atrial appendage. We are scanning the patient, images are coming up, and we see this. Now, it's very difficult to tell on a conventional image whether this is a flow artifact or this is a thrombus, and differentiation is very important from the clinical management perspective. But since it was done on a spectral scanner, we can easily summon our iodine density data. And here we see that this has iodine in it, which can we can not only tell that there is iodine in it, we can also tell the amount of iodine, which is 2.24 milligrams per ml on the iodine density results. And there's no doubt that this is a flow artifact and it is not a thrombus. If it was done on any other scanner, then either we have to scan immediately, or do a delayed scan, but for that we need to have astute technologists who can recognize the abnormality when the images are coming up, or it has to be supervised by the physician, resident, or a fellow, which is not possible almost always. Or we will have to get the patient back at some other time and do the delayed imaging, or send the patient for echocardiography to differentiate flow from the thrombus. But what I call this is a 10-second solution. We can summon up our iodine density results, and within 10 seconds we can confidently tell whether this is a thrombus or this is a flow artifact. And this is very reassuring for the patient, and it's a good practice for our referring physicians also, and definitely very, very convenient for the patient. Here's an example of a filling defect in the descending branch of the right pulmonary artery, which looks almost similar to the attenuation of the main pulmonary artery. Now it's difficult to tell whether this is just a flow artifact from the poorly opacified pulmonary artery, or it is a thrombus. But if you go to our 45 keV spectral result, we see the difference between the thrombus and the pulmonary artery is pretty clear. And we can, if we are still not sure, we can put ROI and we can see the lack of iodine in that filling defect, confirming that this is a thrombus. Sometimes we can see a little bit of background noise, which is about 0.3 milligrams per ml. This is a patient with chest pain, and in the conventional image, we see there is a small penetrating ulcer in the ascending aorta, and a couple of slices cranial to that, we see presence of linear density in the wall. Now, it's very important to differentiate here whether this is early dissection versus calcification. So we can summon our virtual non-contrast results, and here we see that it is actually calcification and not aortic dissection. It's very, very reassuring for the patient. And these all can be automated on the system, so we can get maps automatically. This is a patient, a 69-year-old woman with a history of urological malignancy, with history of central line placement, and on the conventional image, we see a filling defect at the junction of the brachiocephalic and the supia vena cava. It's difficult to tell here whether this is a flow artifact or a thrombus just on the basis of the conventional image. But since we have spectral results available, we can summon our iodine no water results, and we see that there is presence of iodine in that filling defect, and that is very nicely shown on the color overlay image. So this is flow artifact and not a thrombus. Very reassuring for the patient. Again, if this was not available, then next option would have to send the patient for Doppler evaluation, or maybe do a repeat study with delayed images. This is a patient who has calcifications around the right hilum, and the differential consideration is calcified lymph node, vascular malformation, or enhancing vascular mass. It is difficult to differentiate these on the post-contrast images unless we have non-contrast images, very, very difficult to differentiate. But we can summon our virtual non-contrast image, since that is available in the spectral results, and we see that these are calcified lymph nodes, and it's not a vascular mass, and it is not enhancing mass. This shows example of patient with large body habitus. The BMI was 40, and the spectral results are pretty nicely demonstrated, and this shows that the technology is robust even for a patient of this size. This is a patient with history of small cell lung cancer with extensive multi-organ metastasis. On the cardiac CT, we see presence of a mass or a filling defect in the left ventricle. It's difficult to tell here whether this is a thrombus or this is a metastasis. And on the spectral results, we see the presence of contrast which is almost similar to that what we see in the myocardium. So this is not a thrombus, but this was metastasis. Is very, very important from the management perspective. That's the end of my presentation. Thank you.
Thank you so much, Dr. Danrad. It was a wonderful presentation. And before we move on to Dr. Kelle, there are two different questions that are very specific and technical related with this that I would love if we could take a couple of minutes to address. The first one is related with the only energy spectrum used with the dual layer detector. So one of our attendees asked with the dual layer detector, you scan with 1 kVp, correct? So can you elaborate a little bit on this one?
Yeah, that's a very interesting question. First of all, let's think a little bit about it. So since the CT scan was invented, it was always a dual energy system. Was dual energy data was available in the X-ray tube when the X-ray came out of the tube. Only problem was that we were not able to differentiate the different energies. So one method was to get different energies at the source end, which those are the three scanner system I talked before. But then I think the great development is to have this ability at the detector end. Since we have the detector that can differentiate between the high and the low energies, so we do not need to have any other elaborate mechanism to have two different data sets. So this data set is always available. So the energy which is coming from the X-ray tube is polychromatic. It has different energies of the X-ray tube. It is differentiated into the lower and high energy at the detector level in the spectral CT. And then we can tease out any energy that we want. If you want to have 40 kV energy, we can have that. If you want to have 200 kV energy, we can have that image result. Or we can do the fusion, or we can do what is called decomposition of the data. So we can differentiate between calcium and iodine. So that all is done at the post-processing aspect of it, not from the source side.
Yeah.
I
I
hope
think
that
that's a
answers the
very
question.
important point in the terms of the post-processing capacity of doing that. And I'm particularly intrigued by the ability of differentiating artifacts and the ability of actually differentiating thrombus. You gave the example on the left atrial appendix, and also related with that, we have other question from our audience that asks if you are reliable, if you can reliably differentiate or detect pulmonary embolism in the subsegmental level with spectral CT. So that was more towards the pulmonary embolism. I don't know
That
if
is
you
again
can
a very
speak to
interesting
that.
question. And
Yeah,
since it's a little bit different from the cardiac part,
that's right.
but that Z effective spectral result, which I showed in one of my slides, we can use that to look at the pulmonary parenchyma. So in fact, in our department, when we try to do all our PE protocols on the spectral CT, the reason for that is if we are not able to see the embolus in the pulmonary artery in the first go, we always have a backup perfusion map of the parenchyma. So we go what is called a Z-effective map, and we look at the pulmonary parenchyma. If we see a wedge-shaped defect in the pulmonary parenchyma, then we go back and look at the vessel. So in fact, it is a better system to look at subsegmental pulmonary embolism, because we can look at the perfusion map of the lung parenchyma using Z-effective results.
Very good. And we'll have opportunity to continue talking. So, but I want to make sure that we move on also to our next speaker, who I have the honor to introduce, Dr. Sebastian Kelle. So Dr. Kelle is a professor of cardiac MRI and head of cardiac MRI and director of MRI Core Lab at German Heart Center in Berlin and Charité University Medicine of Berlin. So Dr. Kelle, very much looking forward for your talk, and back to you now.
Dear colleagues, thank you so much for the kind invitation to present state-of-the-art cardiac MRI with our new Ingenia Ambition 1.5T and cardiac findings in patients with COVID-19. In a recent statement paper of the European Society of Cardiology, the colleagues mentioned that we should change our thinking about imaging parameters. So we should go away from assessment of the ejection fraction to assess myocardial strain. We should assess the function of the heart at rest and stress. We should go from morphometry to function, and also should perform less invasive examinations and perform more non-invasive examinations to assess also the perfusion of the heart. And all these parameters can be assessed by cardiac MRI. Conventional cardiac MRI parameters include those like the assessment of LV and RV, mass, volume, and function. And that's also parameters recommended by the FDA if you are performing clinical studies to demonstrate a treatment effect. You can assess very easily due to the three-dimensional possibilities, the RV function and RV mass. You can assess fibrosis of the myocardium, acute and diffuse or focal, and also assess myocardial ischemia. And all these parameters, including late Gallium enhancement, are proven for their diagnostic accuracy, reproducibility, and also for their prognostic value. New CMR parameters include those like the assessment of strain, of the LV, of the right ventricle, and also of the left atrium, longitudinal and circumferential global strain, then also new parametric mapping methods like T1 and T2 mapping, T2 star, and the assessment of diffuse myocardial fibrosis, like the assessment of extracellular volume and collagen volume fraction. In addition to that, other parameters are on its way, like the assessment of vascular function, pulse wave velocity, and wall shear stress, for example, 4D flow. And these parameters are those which have now many studies coming out demonstrate their diagnostic accuracy, and first studies also already demonstrate in single parameters their prognostic value. However, we have been the great opportunity since last summer to use the new Ingenia Ambition 1.5T at the German Heart Center, Berlin. You can see here a few images. You see it's a pretty old building. This previous Rudolf Virchow clinic, built more than 100 years ago. And you can see from the building itself, it was pretty tough to get the magnet into the scanner room. However, at the end, we got the nice machine running, and we are pretty happy about this because it has a lot of advantages. And this is something where I was asking myself, my team, and also myself, what is the advantage of having this scanner for cardiac MRI? First of all, it's the newest technique available. It has a digital coil system covering the whole body from the head to the feet, as a wide bore, because our patients are getting more and more obese, so it makes it easier to get them examined, and also in those with, who are claustrophobic. We can use vital eye technology. It's very user-friendly, also from the handling. We have new monitoring systems, and the scans are running very robust, which actually increases our workflow, and we can speed up our exams by using compressed sense and SENC, for example. Also angios, like using 3D non-selective sequence without contrast, using M-Dixon sequence to differentiate between water and fat. And actually, we have only low helium with this new scanner system, which also decreases significantly the maintenance cost, which makes our CEO happy. As I already mentioned, the BMI, at least at our institution, is increasing, and I think this is the problem for many colleagues. And for echo, however, with the wide bore system and the newest scan availabilities, you can see here example of a case of our institution, patient with a BMI of 47 and anxiety. You can see the survey scans already demonstrate very nice images, and also the senior 4-chamber demonstrate excellent image quality in this patient. Here, one of our youngest patients, a 60-year-old female patient with a history of aortic isthmus stenosis and stent implantation. And you can see on the left-hand side very nicely the implanted stent, and the mismatch demonstrated also here on the right-hand side of the stent with partial occlusion of the left subclavian artery, here indicated by the white arrow on top, which can be nicely demonstrated to guide future interventions and can be combined with flow measurements to assess the hemodynamic relevance of this stenosis. One of the main indications are, of course, cardiomyopathies or valve disease. And you can see that here on the left-hand side, a patient with atrial fibrillation and severe aortic valve stenosis can be nicely demonstrated here and quantified. On the right-hand side, a patient with dilated cardiomyopathy and significant mitral valve insufficiency. In addition to that, you can see here the evaluation of the aortic valve. You see the 3D non-selective scan. This can be combined in the same patient and also with flow measurements. And all of these scans can be assessed contrast-free and with a high diagnostic accuracy. Here, another patient, we are seeing increasing numbers of patients with suspected amyloidosis or proven amyloidosis. And a patient here on the AFib, you see the typical pattern like enlarged left atrium, thickening of the myocardium, stiff ventricle, so no longitudinal shortening, pleural effusion, so typical signs already for amyloidosis and really proven by the LGE images with the typical pattern of the contrast within the myocardium. Then, for example, cases with acute inflammation, with case here of myocarditis with increased signal at the T2 weighted images, and also typical epicardial enhancement at the LGE images. And CMR has actually really increased also. The recent ESC guidelines published last year demonstrate that especially in those patients with myocardial infarction with non-obstructive coronary arteries, MINOCA, CMR really stays in the center for the workup of those patients and has a class 1B indication to search for the underlying cause of the symptoms like obstructive CAD, Takotsubo syndrome, other cardiomyopathies or myocarditis, for example. So it has really proven its role and it's right in the guidelines, and we should really use that also in our patients. Here, a patient transferred to our institution for a vasodilator stress exam. You can see here at the 3-chamber view the aortic valve insufficiency, and at the stress perfusion also in the left LAD, in the LAD territory, the perfusion deficit with a hypointense signal there demonstrating myocardial ischemia. We are seeing an increasing number of patients with cardiac devices, and then sometimes the questions comes up, is that a patient suitable for a CMR exam? And in most of the cases it is, if you follow the recommendations, how to scan these patients. If you do this, then this can be done in a safe way for the patient. And as you can see, there are only at the survey scan minor artifacts seen at the image. You can perform T2 weighted images very easily, mapping sequences, LGE sequences, and even in those patients, we can see here our new monitoring system with arrhythmias, demonstrated here by the arrhythmogenic ECG. You can perform nice senior images. You can see here the artifact, the RV by the lead. However, the LV itself, the assessment can be performed easily, also on a short axis, and also a perfusion and stress perfusion, for example, can be performed easily in those cases. A new sequence which can be performed within one heartbeat and in full bracing, which can be used very easily, also, especially in those patients with arrhythmias, is SANC, an acquisition-based method to assess the volume, function, and especially strain of the myocardium. You can see here the original images on the left-hand side, and on the right-hand side, the color-encoded images of the strain, circumferential and global longitudinal strain. And this can be used in those patients where you have trouble to get nice SSFP-Cine images, as you can see here in column D, and you see here the ECG, which looks horrible. However, strain assessment and LV function assessment by using SENC can be used here very easily, and also the same to check, for example, cardiomyopathy cases where you can detect underlying diseases very easily. In a recent publication, together with our colleagues from 2 other centers in Germany, we have been able also to demonstrate that the amount of affected tissue of the myocardium is very important to detect already early stages of heart failure. And this is a publication in JACC imaging, demonstrating that at early heart failure stages, especially at those patients already at risk, just with risk factors, however, normal EF, the number of normal myocardium is already decreased. And this is a window actually where you can interact and try to push these patients to a better stage to improve their outcome. And this is something you can assess with, for example, SENC sequence. However, for all these exams, it's important that we really stick what is the clinical question, and therefore workflow is really important, and to be quick to make it really comfortable for the patient. And therefore tools like the post-processing is also really important. And this is something where, for example, IntelliSpace Portal helps us to increase the workflow by auto segmentation systems to assess the LV and RV function, volume, and mass. And this can be assessed within a few minutes, and then we get reliable results in our patients. Same when we check for neuroparameters, as I mentioned before, going away from just the assessment of LV function and ejection fraction to the assessment of a quantitative parameter, the myocardial strain. This can also be easily done with the newest post-processing software tools available with the IntelliSpace Portal. And if you have a patient with, for example, valve insufficiency, you can use 4D flow analysis for tissue tracking and can quantify the flow pattern and visualize them. And this helps actually also to get better diagnosis in your patients. However, now a few words to the recent pandemic situations and how CMR can help in this perspective. There's a nice editorial published in the European Heart Journal last August, and it demonstrates very nicely that not only the lungs are affected in those patients, also other organ systems. And there are many publications coming out now, right now, like affecting the kidneys, the brain, other arterial systems and venous systems, causing thromboembolisms, and also the heart. And very often the question is, does it cause a direct myocarditis? And the Society for Cardiovascular Magnetic Resonance has published a position statement paper and also study protocol papers how to perform cardiac MRIs under pandemic situations. And what is really helpful in those conditions, for example, we have at our institution, because we have several scanners, also the ability to use a really dedicated COVID-19 scanner for all kinds of indications. And in this position statement of the SCMR, it is the recommendations can be found. And this is something what I would recommend to you if you would like to read further on this topic. And also the question is, what kind of patients do we see? And there are study protocols described with minimal and moderate scans you should use in your patients. If you have someone with CMR indication, like for example, LV or RV dysfunction, suspected myocarditis or myocardial infarction with non-obstructive coronary arteries, and also in patients, if you have, in children, if you have young patients with suspected hyperinflammatory syndrome. Here is a case report in a patient with severe myocarditis in a 19-year-old female patient. You can very nicely see also at these images at the CT that the coronaries are free of any disease. However, at MRI, you see the infarcted or tissue-weighted here accumulation of contrast, and you see at the parametric mapping and T2 weighted images the edema in this patient. In one of our patients, we have seen that myocardial infarction was overseen because the patient reported about dyspnea, and that was interpreted as something related to his lung disease. However, what was the cause was, by the way, decreased LV function, thromboembolism within the coronary arteries, which caused an acute myocardial infarction. Seen here also in the edema at the T2 weighted images, perfusion defect at rest, late enhancement accumulation, and this is the ECV map demonstrating increased ECV volume. And at the invasive procedure, you can nicely see the thrombi and ulcerated plaques within the coronary arteries. In the first and large CMR study published from a group in Germany, they demonstrated in patients examined after weeks and months post positive PCR test. Some of them have been intubated, some of them have been just ambulatory treatment, that they found an increased number of for T2 weighted T2 maps and also native T1 values. And they said that in up to 78% of their patients, they found any kind of cardiac involvement, and in almost 2/3 of their patients, myocardial inflammation. And there have been many comments on this paper, and how can we translate these findings into daily clinical routine. When we check actually the guideline recommendations how to diagnose acute viral myocarditis using CMR, then there are some main criteria and supportive criteria like existence of myocardial edema and non-ischemic myocardial injury, pericarditis, yes or no, increase of ECV, and only if those criteria are fulfilled, then we are talking about a CMR-based diagnosis of real myocarditis. In a group of 26 athletes from the US, our colleagues demonstrated that in these young patients, they found in up to 15% cardiac MRI findings suggesting myocarditis. So in a really much less than described before in the other paper. At our institution, we have evaluated so far around 70 patients post COVID-19 and compared a few of them to patients with myocarditis. And when we checked our values for T1 mapping native and ECV, we have seen that those with COVID-19 have, a few of them have increased values, but not all of them. And there seems, however, to be a difference to real myocarditis cases. And this is the same when we check T2 maps. So T2 mapping values are increased slightly to a normal control group, however, are significantly lower than compared to those patients with real myocarditis. And the interesting thing is also that those parameters actually, usually you see a decrease in myocarditis cases, and in those with COVID-19, it also takes some time that those values decrease or they even stay the same because they are not really elevated. And in those patients, I think we need more data and more multi-center trials, especially to demonstrate the value of CMR, and it should be really used when a clinical indication is proven. So that means clinical symptoms are there. What comes next for cardiac MRI? In this perspective, we have to say that in Germany, there's a huge study running. Our institution is leading the study with mobile cardiac MRI. What we do is we quantitatively assess early heart failure in patients with risk factors. We have a 10-minute protocol. These trucks are running in rural areas, and the MRIs are evaluated in central cardiac MRI expert centers. And we hope that we can improve the healthcare and increase quality of life of the patients in those rural areas, not really in the near of a dedicated cardiac MRI center, and also reduce cost in the future. To conclude, at our institution, we are really happy to offer the newest state-of-the-art cardiac MRI to our patients because we have the newest technique available. It's a very robust, patient and user-friendly scanner and scans itself. It's offering acquisition of high-end CMR examinations where we really can answer the clinical questions. We can offer quantitative and short tests really dedicated to the clinical question and get an answer to this. And this definitely improves our clinical decision making and also our workflow. In patients with COVID-19, we are seeing more and more cases. Right now, we are seeing 1 to 2 patients post-COVID-19 at our MRI suite with various indications. You should follow the recommendations of the guidelines, how to perform CMR, and then the protocols which are recommended. Short protocols are available. And what we really need is, of course, large databases. And the findings in this COVID-19 pandemic will help us so to understand better other infectious diseases like influenza, for example, how this affects the heart. With that, saying that, I would like to thank the whole team of the German Heart Center, the technicians, the MDs, PhDs, and all the fellows. And we are also offering education in cardiac MRI, and we are accredited by all the major cardiac societies, also worldwide. So please check also CMR Academy. And thank you for your attention, and please stay safe. Thank you.
Thank you so much, Dr. Kelle. Thank you for your brilliant presentation. And now we'll have some time to discuss and to bring up some questions that are sent by the audience. So if you have any questions, just feel free to add, and that I will make sure that they are discussed here. If we are not able to address all the questions, we'll try to type answers if not discussed here verbally. But I would like to start by one of the keywords that I identified coming from both of your presentations, and that was workflow. So, in your presentation, I'll start by you, Dr. Keller, mentioning the workflow for automation and the transition from what used to be done in cardiac MR and what it's done today. And Dr. Danrad, you mentioned the workflow in terms of being able to make better diagnosis and not having to bring patients back, not having to send patient even to other modality. So starting by you, Dr. Kell, could you elaborate a little bit more of what has been the change in the dynamic of a CMR with automated protocols, and what do you see changing in that regard?
Yeah, this is a very interesting point you bring up. I think the nice thing is that when we use standardized protocols and standard sequences, today they offer much more than just the information we get from a visual assessment of the scans. So we can, using post-processing, to quantitatively assess new data, which are very, very robust out of this. And doing this, we can actually speed up the whole examination because we can perform robust scans using them to make a diagnosis in the patient and to influence treatment. And for these points, it's very important to stick on the clinical question, not to do everything what is possible in the scanner, just perform a short, quick, patient convenient scan, and then having a tool available which has a high robustness also to perform the post-processing, that we can use these data very quickly in reports. But it's not only the scanning, I think, from the workflow itself, it's also everything what surrounds this. That starts when the patient arrives at the hospital, that the time of waiting, preparation, maybe you have two doors in the scanner room to enter the scanner itself. So that's our single tiny things, but all of these puzzle pieces, I would say, they increase the workflow.
Yes, I can totally relate with that. And Dr. Danrad, is that your view as well? Something that you would like to add on the CT perspective?
Yeah, as far as spectral CT is concerned, I would, if people ask me, and I just tell them that it is a conventional CT scanner that morphs into a spectral CT scanner or a dual energy CT scanner on demand. So there is no change. So the workflow, our flow, that was one of the big things that blew us away when we got the spectral CT, how easily and seamlessly it integrated into our workflow. Not only from the imager side who reads the cases, but from the technologist perspective, from the patient's perspective, it very seamlessly and it seamlessly integrates with the system. And of course, there are many advantages. And in fact, the literature says that 2/3 of the time when dual energy data was useful, it was on the incidental findings. And incidental findings, by definition, we cannot know beforehand. So we cannot either either we have to do dual energy on all the patient if we use some other system, or we have a spectral CT in which dual energy is available whenever we want. And another thing is that if you want to read some data as conventional CT, just read it as a conventional CT. If you find something, then open up. It literally takes less than, it's just one click, 10 seconds, and within a couple of minutes, the different spectral results, whichever you want, can come up. And in fact, on the system, you can create templates. Like I have a template for the cardiac work. So I don't have to go and find out all individual spectral results. I just click on that template and the layout that I want, the images come in that way, and it is very convenient to do the analysis.
And related to that, and before I move to other of the questions more associated with COVID and protocols, I see some questions from the audience asking about the spectral dose in every scan and the time of each study and the scanning time. So if you could clarify that to our audience, I think it'd be appreciated.
So radiation dose is same as any other conventional scanner. So it is dose neutral. That's what my presentation said, because we are not scanning twice, we are not using two tube, and we are not doing KV switching. So the dose is same. One caveat is that currently, with current technology, we have to have a 120 kVp instead of 100 kVp. So that we can scan at 100 kVp also. This is kVp of the X-ray tube. But that will not give us dual energy data. To have a dual energy data, we have to have kVp of 120. I'm sorry, what was the second part of it?
Was the time of the scan?
Yes, time of the scanning is exactly the same, like any other conventional scanner. So there is no additional time. So you get all the benefits of a conventional scanner, less complex workflow, and you also get the benefit of dual energy by the spectral CT, because the data is detected and teased out at the detector level and not at the source level. So that's a huge advantage. And what in our system, what we have done is that we also save the spectral data on our packs. So that takes about 3 times more space than the conventional data. But for us, the good part is that in future, we can always bring back that data and do newer maps if we have to do. Suppose for research or for the patient care, if we have to generate new maps in future, or then we can do that. We can get the new spectral results also in future. So we save our spectral data also on the packs. And some of our colleagues were so thrilled by this, they don't even want to go to the separate viewer. they want the spectral results to be sent as a separate sequence on the packs. So we send them as a separate series. So for all our oncology patient, for the abdomen, we send iodine density spectral results on our packs as a separate series. So they don't have to open up anything. They just look at that series.
And it's incredible how much those details can be meaningful in a day-to-day practice, right?
Yeah,
So
I mean,
thank
each if you can say, I would say that it takes about a couple of minutes to look at the images, but remember that your couple of minutes of investment is saving maybe a day of wait for the patient to get a repeat study, or a physician who will get results will not get the final result till we do a repeat study or you follow-up study. So that way it is patient care wise, it is phenomenal. It's
thank
phenomenal.
you. That's very helpful to get clarity. And now a little bit back to the COVID questions and to Dr. Kelle, there's a question from the audience wondering of the time that it takes to do the CMR and if there are specific protocols that you are using at your institutions for COVID patients. And I would broaden this question to the thought process of the more requests that we are seeing in patients taking advantage of having a cardiac MR, especially heart failure patients. How are you dealing with that pressure of having to adapt to these circumstances for patients with COVID and for heart failure patients?
Yeah, I think for COVID itself, you have to differentiate between acute COVID or acute SARS-CoV-2 infection in patients who are infected by themselves and those who are at the convalescence stage, because they can be scanned safely in a normal scanner environment. For others, we have the great opportunity that we can use a dedicated COVID-19 scanner where we perform all the scans, also from the brain, stomach, and others in acute COVID cases. And in the other scanner, if the infection has been taken more than 4 weeks ago, then we can perform the scanning safely also in a normal environment. And from the SCMR, it's open access, is available to everybody. Position statement how to perform these scans, that they are safe for the patients and also for the technicians and physicians, and also a protocol paper which recommends that the minimum requirement for a protocol should be the assessment of the heart function and volumes. So that means senior SSFP sequences, state of the art. Then in addition, also T2 weighted images and LGE images to assess fibrosis of the myocardium or pericardium. So that would be the minimum what you should perform in those patients. And this can be done in 15 to 20 minutes if you use a quick protocol.
It's very helpful to clarify 15 to 20 minutes. So that would be the time of the protocol with the minimum requirements.
That is correct. If you would like to follow, of course, the updated Lake-Lewis criteria to diagnose myocarditis according to the recommendations published 2 years ago, then you should also use mapping sequences. And then this protocol takes longer, so that the protocol is in a range of 25 to 30 minutes. But this is only the scan time. Of course, it always takes to prepare the patients. At our institution, we have an SOP written that after COVID patients, we have a time frame of a minimum of 15 minutes just to clean the scanner room, get fresh air in, clean everything before the next patient is entering the scanner. And of course, these time slots, this is something you also have to take into account when you schedule your patients.
Absolutely. And that will bring us to the last question because we are on top of our hour. Well, unfortunately, the time goes by so fast. And that relates with the mobile and assessment of CMR. And then I would challenge Dr. Danrad to a thought in the future of the mobility of CT as well. So how are these modalities getting closer to the patient? So are we bringing them to the patient instead of being the patient to them? So I would just like to hear the thoughts of both of you on it.
Right now, we have very nice protocols, short protocols, just in a range of 10, 12 minutes to assess the the heart function and volumes and also strain. And these scans can be performed without giving any contrast or medication. So they can be performed even by a technician. And by using telemedicine, You can also perform the consenting of the patients via online, for example, if the laws allows it in your country. And the assessment of these scans can also be done somewhere in an expert center. So we have this project running in Germany where we serve as an expert center for cardiac MRI reading of these scans. And the truck itself is 300 kilometers to the north and to the south. And it's in rural areas where the landscape is beautiful. However, there is no experienced cardiac MRI imager available. However, you can offer state-of-the-art technique to people live in these areas and actually improve their diagnosing and treatment of heart failure, and can detect early heart failure by this way, and improve, for example, or initiate treatment of hypertension or diabetes to prevent those patients that they have cardiac events. And this also results, of course, in decreasing costs for the healthcare system, because usually those patients, they are in the age of 45 to 55 years. And if you are not treating them right, then in the next 10 years, they will develop some kind of heart failure and will be symptomatic. But this
That's
is a true.
fantastic to hear that we are going to the investment of earlier stage disease, right? That we are improving in our ways of early detection and preventing, which will ultimately bring years to life. So congratulations for that initiative. That's really good to hear. And Dr. Danrad, I will pass along to you for final comments on this topic.
Yes, sure. No, I totally second Dr. Kelle's opinion that we should be bringing technologies to patient wherever we can, rather than uh, putting all the eggs in one basket in a big referral center in a big hospital. Because many of the patients we have seen that they are depending upon their functional status and socioeconomic status, they may not have access to the big tertiary center places. And as far as spectral CT is concerned, its footprint is exactly same as any other scanner. There is no really special need for technologists to be trained about it. And all the protocols can be fed in the scanner. So it will generate the spectral results by itself, and it can archive them. So technologist doesn't even have to do anything additional. So potentially this, yes, this is definitely available on the scanner. Our institution did not have any personal experience with this, but I totally agree that with the spectral CT, this is also feasible.
So with those words and with this spirit of continue to offer the best quality of care and improving access and improving the workflow, I would thank you very much for your time here today and your lectures. I'd like to thank our audience and Aunt Minnie for also allowing us to put this together, and wish you a wonderful day, and looking forward to connect again. Thank you so much.
Thank you very much. It was our pleasure.
Thank you. It was a
Thank
pleasure.
you. Stay well. Bye bye now.